Okay, all right. So I would like to welcome you both. I'm very, very excited to, interview both of you. I think without, I don't know if you guys need introduction, but, Professor Felix, we've been talking a little bit before we started this interview, but he's been in practice for over 30 years. Initially, he's been in private practice and he recently retired. And Dr. Felix is very well known. He trained under Dr. Nihas and very, very prominent surgeon. Doesn't really need any introductions in both general surgery, bariatrics, hernia, and you name it. So welcome, Dr. Felix.
Thank you. But it's been 30 years in laparoscopy. Let's go almost 50 years in general surgery, which is, I'm getting old. Antique.
Never old enough. And then Dr. Daes from Colombia. Dr. Daes also has been in practice. How many years, Dr. Daes?
Over 35 years.
So very similar. Also I did not know this, but Dr. Daes, instead of, in addition to hernia, he does a general surgery, bariatrics, foregut, and a lot of other things too. So, welcome. We're very excited to have you both here today.
Thank you very much for the invitation.
Well, thank you. So just to kind of get started, I think, everybody knows, your paper that came out in 2017 about the critical view of the myopectinal orifice. The reason we wanted to bring this up is that I don't know how many residents or fellows out there that know this paper by heart. It's very, very important for surgeons in practice that are doing MIS, inguinal hernia repairs. I usually ask residents about it, do you know about it, and etc. So just wanted to pick your brains on what was the main reason you guys decided to look into this and publish it and make it known to people out there.
You want me to take it, Jorge? Or?
Yeah, please.
But, it all stemmed from the actual paper was Jorge's idea. So, yeah, he's shaking his head, but it was. But what happened was I was giving some lectures about what somebody coined as my commandments for hernia repair. And then the IHC came out with the idea of the critical view. And then one day, Jorge and I were actually standing together at the college meeting and watching people do hernias for the industry. And it was a travesty, as my boss behind me used to say, Nihus. It was terrible. They were not doing what we had been describing for 20 some years, 25 years. And so he said, why don't we put this thing together? And so he started it and then we did it together, but it was to try to correct what was going on. The people had sort of strayed away from what we and others had shown. We weren't the only ones. We had shown was the right way to do laparoscopic inguinal hernia repair. They had kind of invented their own techniques and were actually propagating them at national meetings in front of audiences. And so I think to me, that's why Jorge said, let's do it. And he started it and then we collaborated on it.
Dr. Daes?
Yeah, I totally agree with Dr. Felix. Two key factors influenced the decision to publish the critical view. First, surgeons were performing minimally invasive inguinal hernia repair, adopting new techniques, technologies, material, and equipment without sufficient evaluation of results. And therefore, the standardization remained elusive, despite many areas of consensus. And secondly, despite over 30 years since the first laparoscopic inguinal hernia repair, their acceptance was limited to only 10 to 15% of all repairs. So the introduction of robotic approaches increased the percentage of minimal invasive inguinal hernia repair significantly, now accounting for almost 50% of inguinal hernioplasties in the US. However, this rapid growth led to many repairs being performed without considering the lesson learned from years of experience, which have resulted in low recurrence rates and reduce incidence of chronic pain. So social media, serving as a platform for widespread communication, including videos and live surgery, has highlighted this phenomena, people doing procedures without really having the lesson from the past. So that was the idea behind trying to standardize the common pathway of any minimal invasive inguinal hernia repair.
Yeah, actually, to reinforce what Jorge said, I think that not only does the internet is a very good way to teach, but it's also a good way to teach bad habits, and that's what was going on. It was being propagated, worldwide, and it was interesting that people were not adopting what the experts had been doing. I mean, no one really had. It spelled it out, I think, was the problem. No one said, do this, do this, do this. We all just did it, kind of a gestalt feeling. So that's why Jorge was motivated to do it. And I think we were very lucky that the Annals of Surgery accepted it. I think it was Jorge's hard work and diligence, because they originally did not want to accept it. But now it turns out to be one of the most downloaded papers ever published in the Annals of Surgery. So it's they've kind of changed their tune.
I thank Ed for his kindness, but to tell you the truth, Ed has his commandments before that. It basically is how to do a proper minimal invasive inguinal hernia repair. We simply put it in a better way, very simplistic way. We just change one or two numbers and standardize the process. That's the clue. Standardization of the procedure is, I think, the main contribution of the Critical View article.
Yeah, these are all excellent points. I think I mean, I personally learned from it a lot, even just doing this or being trained to do MIS inguinal hernia repairs before it came out. But I personally, when I looked at it, I was like, wow, I need to change some of the things that I learned.
Thank you for providing some of that historical insight. I'm fascinated by this topic, and you alluded to this in your answer for the first question, but now looking back over the past 7 years since the publication of this article, what was the reception to it, and how do you think it's been adopted? Maybe the initial reception to this concept of the critical view of the myopectineal orifice, and now 7 years later, how has it been received?
Yeah, I think the reception has been fantastic. I think that much more than we ever thought would happen or expected. I think that it is sort of every resident that I know of in a good program is being taught these principles, and even established surgeons have said to me that they'll realize they forgot a step. Notoriously, it's the removal of the lipoma. And they realize, well, I missed that step, and then they go back and do it, and so I think the acceptance has been fantastic, and I think it's had much more importance or influence than either Jorge or I ever dreamed or expected. I thought this was just going to be a little thing, but it's been much more.
Yeah, I agree with that. It's difficult to quantify the influence of the concept objectively. However, the largest hernia-focused social media platform, the International Hernia Collaboration, shows a trend toward using the steps during any minimal invasive inguinal hernia repair. We believe the concept has reached the specialty globally, as evidenced by interactions with residents and fellows worldwide. So I think it's a good influence. We always suggested to consign the steps, the completion of the steps in the record, in the surgical record. That's a good way to not skip any step.
Yeah, absolutely. I think I recently saw an article that was scrutinizing that specific point, Dr. Daes, about whether or not, I think there was a retrospective review looking at operative records and seeing if folks were adhering to the principles of the critical view. And I can't say, I'm embarrassed to say I can't remember the results of it, but certainly the specific results, but certainly there's been an uptick on, quotations from the critical view steps showing up in some of the operative reports.
Yeah.
You
What is interesting is very difficult to quantify the effect of the steps in the recurrence rate, for example, because you would need thousands of procedures and then evaluate the low recurrence rate we have today to just pinpoint which steps was skipped or not completed. So it is very difficult to demonstrate the influence. Well, the influence you can demonstrate, but the numbers of the influence of the critical view on the recurrence rate. So we're thinking about that with other groups, how to quantify that. Maybe by evaluating the recurrences, we can pinpoint if some steps were not followed. That makes sense. Otherwise, we have to follow thousands of patients, and it is very difficult to do.
Dr. Felix, you're about to say something.
Yeah, I think in some ways when you talk about documenting, it's almost like the gallbladder, and that's where the nice word, the critical view, comes in. I do a fair amount of medical legal stuff, and it's very important to document that when you're doing a gallbladder, that you've followed and established the critical view. So I think the same thing is becoming true of when you do an inguinal hernia repair, that it makes you think about what you're doing. And when you document it, it makes it better for you in the long run if something else were to happen. So I think there's lots of reasons to do it. Not only does it make your repair, we think, better, but also you can then document what you did.
Question is like, or is there anything new or novel after, you guys published that in 2017, or is there anything or modifications or anything new or updates that you can tell us about, or you think needs to happen?
Well, yeah, Jorge wasn't involved in this one, which was my fault, and I apologize to Jorge for it. But the Brazilians wanted to add their idea of the zones, and so that second paper was just adding to the critical view the zones, and I think what that paper brings out, as well as what Jorge and I talk about a lot, is the rules and the steps are to be followed, but the order that the steps have to be followed are not always the same. And you have to learn to be able to modify how you do it according to the hernia itself. And I think that is pointed out in that second paper, because their steps are in a little bit of different order. And I think that's important for residents to learn, whether you're doing hernia surgery or whether you're doing colon surgery, or like I did a lot of head and neck surgery, how you do it and in what way you do it, where you start may be different, but you have to complete it in the same way. You just don't always go 1, 2, 3, 4, 5. You may jumble up the order according to what you see. I think that's important. And I think Jorge talks about that a lot. Don't you know, Jorge?
Yeah. Well, I really understand the rationale behind this article, combining the old anatomical triangles with the concept, the CV concept. However, this publication created a little confusion by including maneuvers specific to a particular technique, for example, TAP, in a concept intended for all minimally invasive inguinal hernia repair. Moreover, it altered the terminology of the steps, complicating the standardization process. So the main goal is step 6 must mean the same for everybody. That means any resident should look for and reduce canal lipomas. That should be step 6. So that created a little bit confusion, but it was a well-accepted article by the public. So we have to live with it.
Yeah, it was translating the Portuguese was the problem.
Yeah. We've sort of talked a little bit about how there's been a huge uptake of this concept by various groups, but Do you think that this should be formally integrated into a resident surgical curriculum? And if so, how? Certainly, I can tell you in Canada, this is only informally being taught by folks who are familiar with it. How do, should it be, and how do we incorporate it into a formal surgical curriculum?
Go ahead, Jorge.
Okay, but I think the concept of the critical view should be included in the resident curriculum for sure. And the surgical resident reference textbooks, such as Savistone, are now incorporating the concept. I was invited to comment on that into the upcoming editions. Additionally, including the critical view in the surgical record could serve as a confirmation of a step completion and as a marker of a well-executed repair. So there are advantages of really incorporating the concept into the records and into the surgical practice.
Yeah, I would totally agree. I don't care what the residencies or fellowships call it. Part of the problem and why it's not incorporated is because I don't want to use the word jealousy, but everybody thinks they want to put their name on something. We don't care what you call it, whether you call it the critical view or the commandments. We know now, after almost 35 years of doing inguinal hernia laparoscopically, that if you don't follow these rules and complete the steps, you're going to get recurrence and have problems. And so I think that I don't care what the residencies call it, but it's something that they should be teaching and should be part of the curriculum. They can put whatever name they want to call it. If they want to call it the Mass General or the Brigham or the Duke, that's fine with me. But I think that what we've seen over these 30, it's almost from, we did the first lap hernia in I think it was 1992, something like that. And things we learned, and there's no reason to rediscover the wheel. Okay, it's basic rules. Jorge is trying to demonstrate, as he's doing a nice study of reviewing videos to try and demonstrate, as he said, that this proves you can do a better hernia repair, but it's going to be very tough to do. No.
In our favor, we should say we never use an eponym precisely to not put this. There are many surgeons, especially Dr. Felix, should be the commandment of Philip or whatever, but we avoid that because so many people contribute so much for so long that it's only fair to have a concept that we just put into a paper. So really, we don't want to take any ownership of the concept. We just want people to really follow the rules to avoid recurrences and complications.
Yeah, absolutely. It's interesting to see in the narrative of the original publications and the subsequent publications, the description of the history and the rationale of separating names and persons and letting the merits of the idea speak for itself. And I think that's been quite fascinating and reflects on the philosophy of the hernia community in general. And certainly, I think you folks are right in that it has, like, the natural history of the idea is that it's becoming part of the resident curriculum, and we're just seeing the lag time that it takes for it to make its way through papers, through manuals, and then finally now into the, so to speak, Bibles, the Sabistons and the Camerons and the surgical techniques and so on. So it's exciting. As someone who's studying for my boards, I'm excited to know that new versions of these textbooks are coming out soon, and we'll be seeing these concepts soon. So good.
Yeah, no, that's great. So I guess the next, we're switching gears a little bit from the critical view topic to the AHS topic, and just asking, Dr. Felix and Dr. Daes, what was the reason you decided to join AHS, and what is your advice for residents or fellows regarding involvement in AHS, whether that be, courses, education, coming to the annual meeting, etc.?
Yeah, I think it's super important. I think my involvement is a long involvement, but the reason is basically has more than one. My involvement is for more than one reason. It gives me an opportunity to teach, which I enjoy doing, but also it's where I learn. I mean, where residents and students and established surgeons can go to learn from others and correct the things that they've been doing right or wrong. And so I think that those two are the main reasons. And for young surgeons, I think the opportunity is there to get a mentor. My mentor originally is the guy behind me here, Dr. Nihus, and who got me involved with hernia repair and taught me the posterior repair. I mean, if it weren't for his interest in posterior hernia repair, I never would have come up with the idea of doing it laparoscopically because it was emulating his. So I think the American Hernia Society gives residents and fellows the opportunity to learn from those who are established, and then for them to grow and present. At this last American Hernia Society meeting, I was excited to see, I think Conrad Balasar had something like 5 or 7 of his fellows or residents presenting. And I think it's a fantastic opportunity. And I don't think that, I think residents should be given that opportunity from day one, both to learn and then for them to grow in the society.
Dr. Daes?
Well, I joined the American Hernia Society to engage with peers, obviously, to share the ideas and to learn. And my advice to residents and fellows is to embrace the opportunity the American Hernia Society offers for knowledge exchange, training in new procedures, formal education, and commitment, and the commitment of its members, characterized by their devotion to education, fraternity, and friendship. It's a really special society. I don't know if, because for so many years we were like a set apart, and now we know the importance of exchange, education, and colleague relations. So that's the reason I joined the American Hernia Society, and is the best way to interchange with people who love hernias.
Amazing. Sort of an offshoot on that, I think that's really excellent advice for, young surgeons and residents who are thinking about joining an AHS. But do you have any advice or words of wisdom for whether it's residents or early career surgeons, or even, late career surgeons who are trying to learn novel hernia techniques, especially with the many techniques that are coming up right now, that we hear in both the literature and in social media?
Well, I would advise to move away from the outdated see one, do one philosophy, and really think that learning complex hernia procedures safely and efficiently involves deepening anatomical knowledge, acquiring advanced minimal invasive skills, participating in immersion courses, cadaver labs, fellowships, and what Dr. Felix said, a mentor. So it's a different process of the one we followed many years ago. I think this is the right way to do it. The knowledge is there. The people who are willing to teach is there. The society is there for them. So it's the best moment for someone to specialize in hernia surgery.
Yeah, if I can just plug an editorial I wrote for General Surgery News on this topic, on how education has changed. And I think the American Hernia Society is playing a big part in that. I talked about in that article about learning to operate before you ever get to the operating room, using simulators and so on, and using the lab. But I think the American Hernia Society, in its courses, is partly fulfilling that for residents, especially for residents that may not come from a super named university where they have those facilities. Not every residency program has simulators and robots that can teach robot systems, that are dual systems. So I think the American Hernia Society and their education program has been fantastic for running their courses to do that. Then beyond that, and I know Jorge has been involved in this, I have not, but they've been assigning mentors to young surgeons and established surgeons. So once they take the course, they can have continued view of their videos and editing and refining what they do. And I think that's the most important thing. One of the things why laparoscopy never matched or never got beyond the 10 or 15% that Jorge referred to was we used to run, myself and Guy Veller and others used to run courses. We taught many, many surgeons how to do laparoscopy. But then we'd let them go and they'd go home and they would have nobody mentoring them. And so they'd get very frustrated or have bad results and then they quit. And so only a small number of surgeons, that 10 or 15%, then went on to continue doing the laparoscopic repairs. And so this new form of education where you learn before you go to the operating room, you then are with someone who's doing it, you then have that person either with you or mentoring telemedicine-wise, and then it followed up with more mentoring later. I think that's the big difference, and I think that's what has to be done. You except for the rare surgeon that we just talked about a minute ago, who learns to do a TAR by watching videos, that shouldn't be the way it's done. I think you have to have a whole process. Otherwise, we're going to have the same problems we had in the early days of lap chole and lap hernia, lap appy. If you look back at history of all of those, we had some very terrible results early on. And so I think this new method of teaching will prevent that.
If I can add something, that was the reason of the critical view in a way, because we were witnessing so many surgeons wanted to adapt new techniques without following known rules and steps necessary for success in their field. So in a way, the American Hernia Society is taking the place of really supervising, if we can say that, for those interests, how is developed the correct way to perform a hernia. I was initially resistant to the idea of hernia surgery as a subspecialty, I have to say that, because so many surgeons would be abandoned, let's say that. And now I think it's necessary. It's necessary because the field has become extensive, complex, require specialized expertise for optimal results. So times have changed. See one and do one is no more.
It's not working anymore.
For me, it wasn't even see one. I didn't even get to see a lap hernia. We just did it.
Invent one and repeat one.
Yeah.
But I would differ a little bit from Jorge. I think we need to have a subspecialty for complex hernia repair.
Yeah.
I don't think inguinal hernia, whether it's done open or laparoscopic, for the simple ones, needs to be done by super specialists. There's too many hernias, and I think that's something the general surgeon can do if they're trained properly. That's the key. We have too many old-time surgeons teaching wrong ideas, and I think as fellowships and residencies go on, the general surgeon can go out and do the simple things. But I agree totally with Jorge that I don't think complex hernias, the ones we see on the IHC, some of these really involved hernia repairs and recurrent hernia repairs, should be done by an average surgeon. I mean, we know from other fields that if you do pancreas surgery and you do it a lot of it, you have great results. If you don't, you don't. The same is true of bariatrics, which I did a lot of. It takes an expertise, but I think the simple hernias, yes, can be the purvey of the general surgeon. I don't want to leave them out, but the complex hernias, the recurrent hernias, the hernias that already have mesh in place, for inguinal and so on should be sent off to centers. And this has been true in Europe for a long time. And I think that's why somebody like Bittner has had such great results, is because they do such a high volume. And in Germany, the complex hernias are sent to the centers. They're not done routinely.
Yeah, well, I agree totally with you. I was referring to complex procedure because basic hernia procedures should continue to be part of the general surgeon's skill set due to their sheer numbers. Just that. Nobody can do enough hernias. So what I refer to is we need this subspecialty. In the past, we didn't consider that as an option. Now I think the subspecialty is necessary.
Yeah, no, these are all excellent points, and I think actually our last question was about that. You know, what should you know, is hernia repairs not a craft or art of the general surgeon anymore, and should we be going more towards subspecialization? So you both perfectly answered that question. I think that's kind of a direction where AHS is going also with trying to, you know, have centers, you know, similar to MBS EQIP for bariatrics, for example, have centers that, you know, do these complex repairs and measure outcomes, et cetera, and having actually a registry that, you know, that we could, you know, hold these centers accountable for their outcomes, et cetera.
One of the things you were going to ask, which you didn't, is what can the American Hernia Society do? And I think they can do a lot. I think that it is important for the American Hernia Society to get a hold of residents and fellows early on and give them the sort of feeling of excitement that Jorge and I feel and you feel about hernias. I mean, when I was in training, it's as I wrote in the little piece, inguinal hernia was an intern case, and so there was no give it to the lowest man on the totem pole. And I think what the American Hernia Society can do is to instill this feeling. No, it's not an intern's case. These are very complicated cases. Even simple hernias can be complicated. You never know what you're going to find, and so they have to instill in residents and fellows early on that this is an exciting field. This, to me, it's just as exciting as a gunshot wound to the popliteal fossa. You know, it's exciting, and that's one of the things that the AHS has to do, is instill that feeling in residents and fellows. Otherwise, they're not going to go into the fellowships in the field.
Yeah, agreed. And I think that's a, you know, big part of what our committee is trying to do is having, you know, more involvement, more excitement about hernias, because it's never just a hernia, you know, like everybody's like, oh, it's just a hernia. But yeah. Awesome. Well, I think that's all what we had. I don't know if you have anything else you want to ask, Ben, before we conclude.
But no, I'm certainly the beneficiary of the work that you two and other folks have done in terms of inspiring a new generation of surgeons to get really excited about a growing field, and to now have more of the context of some of these major landmark changes and philosophies in hernia, and now seeing the result of it with, you know, it really becoming a subspecialty with, you know, fellowships like the one I'm doing, and what we're seeing with the Fellowship Council now, really building it as a subspecialization. I think we're seeing a lot of your visions become a reality. So with that, thank you so much for joining us today. I think it's been I've learned a lot from the two of you, and I think we're really excited to share this with the rest of the residents and fellows of AHS.
Thank you very much.
Yeah, no, I was gonna say
our pleasure.
No, thank you so much, both of you, for joining us and taking the time to do this. And I always enjoy meeting with you in different meetings and learning from you all the time, and, you know, reading about what you're doing and learning more and more. So
Thank you very much. It's a pleasure.
Thank you.
We'll see you all in Chicago.
Oh yeah.
Sounds good.
See you.